You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education, elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
All right, case 4, a 61-year-old male with resistant hypertension. Past medical history of coronary artery disease. He's had bypass. He has diabetes, hypertension, hyperlipidemia. I'm going to go back to your point earlier about the picture. It is really hard to find stock photographs of patients checking their blood pressure properly.
Yeah.
But I'm glad you made the point about the Aneroid device.
Yeah.
He's on valsartan 320 and dapamide 2.5 and lidipine 10, metoprolol 25. And he's also on metformin twice daily, insulin, dulaglutide, rosuvastatin. Sadly, Dr. Tuttle, he couldn't tolerate an SGLT2. Okay. These are his labs. His blood pressure is 148/86 on an automated office blood pressure reading. And that's when a patient, it's a protocol similar to what they used in the SPRINT study. The patient's seated quietly alone in the room for 5 minutes, and you have 3 blood pressure readings that are checked and averaged. Sodium 140, potassium 5.1, creatinine 1.2. We've already checked the aldosterone and renin because we're good at this now. UACR again. Oh, I didn't even know I was going to be checking all the boxes for you, but yes. What would you do next for this patient? Most patients starting spironolactone, most of you starting spironolactone 25 milligrams once a day. A minority adding hydralazine, and even fewer adding clonidine and considering renal denervation and abracitinib. What's the panel going to say for this?
I would have given this guy finerenone.
Given him finerenone.
Based on Fidelio and Figaro and Fidelity. His UACR is 300. He's in a hot red box. So besides blood pressure, he's hurtling toward the abyss. He's already had a lot of serious coronary disease. That's the best predictor of GFR decline. It looks good now, but in a year that might be 45 with these guys. And so finerenone is the drug in people like him that has been shown to prevent the kidney outcomes, the cardiovascular outcomes. And interestingly enough, in the Fidelio trial, now finerenone does not have as much blood pressure lowering on average.
Yeah.
But in the more hypertensive, in the people with higher blood pressure, it had greater blood pressure lowering efficacy.
Right.
So I would have given this guy finerenone and then reevaluated his blood pressure because it might be enough for him. You have to find out. But I want to control his blood pressure, but I also want to give him drugs that are likely to prevent the terrible complications, which is why we really care about hypertension.
Great. Other comments from the panel?
I'm glad she's my nephrologist. I totally agree. Now, you made a point in your lecture, and tell me if I am gathering what I should from this point. If the aldo is not elevated and the renin is not suppressed, will spironolactone be as effective if the setting was such that the aldo was higher and the renin was suppressed? Such that I love the finerenone. I mean, you got to think about clinical trials. He's got, the GFR still would have been in the CKD part because of the protein. And, I like the finerenone. Would spironolactone be an effective drug in this patient as opposed to an ASI that might have those non-genomic effects, block the aldo, and, have...
How much would you worry about potassium in this particular patient?
I'm a nephrologist.
A little potassium doesn't scare you.
And I don't want people to be dismissive of potassium, but... like in the aldosterone synthase inhibitor trial, we're allowing people in with a baseline potassium up to 5.2. Usually, again, if you look at the trials, whether they are MRA, at least finerenone or the ASI trials, you're looking at 0.2 to 0.3 millimole per liter increase, maybe a little bit more without an SGLT2. But, if he goes from 5.1 to 5.4, I'm fine with that. Again, this is going to be clinical practice. I tolerate potassiums of 5.5, 6 I don't like. I think in primary care, I need to be a little bit more cautious because sometimes it can get away from you if you're not monitoring it. If you're putting them on a DASH diet and they didn't get the memo that maybe they shouldn't eat so much potassium.
Right.
So it does, I think, to be honest with you, this guy should have a referral to nephrology. He's in a hot red box because of the proteinuria.
That should have been an option.
And that's where I'm going to work with you and try to tweak this. And then, like in this guy, whatever you give him in 2 weeks, I'm rechecking his what we call a basic metabolic panel, his electrolytes, GFR, for safety.
But to get into that original Fidelio trial, I think, didn't you have to have a K less than 5? Or 4.8?
4.8.
Yeah, 4.8.
But it's been liberalized because the rates were so low, and in the ASI trials were going up to 5.2, and we did analyze the finerenone data for safety, we were probably overly cautious.
Yeah.
Now, let me underscore the referral here. So I'm, in our institution, I was the hypertension guy, but if I were seeing that patient in my clinic, I would have referred that patient to a nephrologist. And don't be afraid to say, gee, I can't handle this. It needs some expertise, and it's in the patient.
Well, and again, I can't speak for everyone in the world of nephrology, but people who have that level of albuminuria, which if you actually check total protein is about twice as high. I mean, you're talking about someone who's got a half to 0.8, half a gram, like 500 to 800 milligram per gram of total protein. That's a lot of proteinuria, and half of that's albuminuria. And then again, if you use the heat map, I know it's a very simple thing, but then you get an idea of how high risk this guy is. And if you look at all of the CKD trials, where the events accrue is in the albuminuric group, irrespective of GFR. So you can start at 69, but if you're at 300, within 2 years, he's going to be 40.
Yeah.
This is a guy, they really are hurtling toward the abyss. They need rapid sequence initiation of GDMT and control of risk factors concurrently. And I think I was listening to you all talk about having some urgency about blood pressure control.
Yeah.
I think you're hearing the same song from different points of view. And why are you urgent about it? Because you're worried about complications. It's not the blood pressure per se. It's because high blood pressure causes bad things to happen to target organs.
Right.
And so I think what we're saying is we need to have some urgency about treating these patients. And it's not good enough to bring them back in 6 months, because bad things will happen in 6 months who have uncontrolled risk factors. And then if you already have an albuminuria like that, you're already on the I'm just saying hurtling toward the abyss, because I want to make a point that it's not good.
Not good.
A couple of real quick points. Only 30% of people are controlled with hypertension on one drug. So fixed dose combination, whatever. 70% need it or more. Another point is, I had another point about more than one drug. Oh, gosh.
Well, the other thing, too, I'll bring up, and if George was here, we agreed on most things, but this is something where we might have a little bit of a debate. But I'm not a fan of renal denervation for a lot of reasons. And one is that we have highly effective blood pressure medicines if we can actually get them in people in most cases. And I understand the mechanism, but I also think it's a bad idea to kill nerves that have really important afferent and efferent feedback loops between your brain and your kidneys. We don't really know that that's okay. To me, that would be something that I would reserve as a last-ditch effort. And with drugs like zilebesiran coming out and stuff like that, I'd much rather do, if I needed long-term control without pills. I know we aren't there yet. We have to wait for the trials, but I don't like, cutting the sympathetic nervous system. I mean, there's a reason that the kidney has an efferent to the brain, and the brain has efferents to the periphery, and it's so crude. I mean, you go in there, and we did the trial. I mean, I didn't, but they go in there and they just blast away at these nerves, and I don't know. I just don't like it philosophically, especially when there are options that are not destructive to your body.
The hypertension
sorry.
community.
Other than that, she likes renal denervation.
The hypertension community is split. The hypertension
Right.
community is split.
I love me a good hypertension scandal, people. You're watching this play out in real life. This is a hypertension scandal.
We have reasons for the sympathetic nervous system.
Yeah.
I mean, I don't mind modulating it, but like, I don't know, especially when you look at like mechanisms of how other drugs work, like SGLT2 inhibitors. Part of the way they work is they modulate the sympathetic efferent from the kidneys to the brain, which has other effects on heart and kidney that are good. You lose those opportunities to favorably modulate biology, but that's just, again, Kathy Tuttle's view of the world. It might not mean anything.
Dr. Jones.
So for a primary care clinician, what you need to know about renal denervation is don't refer them to a surgeon. Don't refer them to a person who does renal denervation. Refer them to a hypertension specialist or a nephrologist who does not do renal denervation.
Right.
And let them evaluate
Yes.
the best course for the patient.
And if they think it's necessary, they can do that referral.
Right.
But just to kill a bunch of people's renal sympathetic nerves when you could have managed their blood pressure otherwise, to me seems reckless, frankly.
Yeah. Great.
How are we doing on
I had a senior moment for a second, if you'll allow me to say that. I'm good. I'll come back to me tomorrow morning. I'll get it.
Well, I'm looking at the time. I think in the interest of
35
time,
seconds.
I wanted to just bring up these medications that have been brought up before that are new novel medications. The last time we've had a new drug in hypertension was 2007. So this is really exciting times to be in hypertension. We have 3 or 4 different mechanisms that are coming down the pike for us to be able to treat hypertension with medication. Aprocitentan was just approved. It works by blocking vasoconstriction. This is a graphic from the Lancet trial. It was precision trial that was published in Lancet. You can see there was a significant, even placebo-controlled benefit both during daytime and nighttime. These are patients who had resistant hypertension and a background of 3+ medications. And so patients like the one in our case, so these are known patients with resistant hypertension, a 4 to 6 millimeter decrease in ambulatory systolic blood pressure with a nice nocturnal reduction. There was a black box warning, and you used to have to register for REMS if you've ever prescribed Accutane or had a teenager on Accutane. The REMS is quite something. They removed the REMS requirement for aprocitentan. It's now, but there's still a black box warning for potential fetal toxicity. I just want to speak a little bit about renal denervation again in the interest of having you know that this is out there and know a little bit. You've seen a little bit of a flavor of a controversy in the hypertension community about renal denervation. So this is what it is and how it works. There are 2 different mechanisms that were approved in the United States by the FDA. One is radiofrequency, the burning that was alluded to. The other one is an ultrasound denervation. There's been a lot of conflicting evidence. What you saw play out here on the stage played out in sort of randomized controlled trials. There were trials that hit endpoints, that didn't hit endpoints, that were, different populations, but the technology is here and it's been approved, and I think you need to know about it because your patients will ask about it. It was approved last fall with the vaguest and broadest FDA approval I've ever seen for anything, indicated to reduce blood pressure in patients with hypertension who aren't controlled with other methods. So very, very broad. There could be a lot of different interpretations to that. These are the contraindications who we know absolutely shouldn't get it, and patients in whom we have limited data. That is a little bit of just an image of a radiofrequency ablation that's happening. And let me see, I think I just have, I want to show this one slide and then we can take questions. This is a waterfall plot, and I think this is an important concept. Averages can be really misleading. This is from one study of the efficacy, or looking at the efficacy at renal denervation. And down here you can see each one of these bars represents a patient that had renal denervation, okay? From patient 1 to patient 60 on the far right. And you can see their individual blood pressure response to the renal denervation. Everyone to the left of this arrow had an increase in their blood pressure after renal denervation, and everyone to the right had a decrease. And so this is where we can really be misled by reading studies and papers that show average responses.
Thanks for watching. If you found this discussion valuable, be sure to like, subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.